I'll just start by telling you very briefly why I went into oncology. I was an intern at Penn in 1991, so, I was 12, no. but I was an intern, and the second month I was assigned to the oncology unit. 1991, cancer treatments were not what they are today. That was 32 years ago, scarily enough. And I was assigned to take care of a young man who had a form of leukemia that we really didn't have any treatment for. In those days, all you could do was give blood transfusions. And he was in the hospital, and his wife was 8.5 months pregnant with their first child. And so I was assigned to take care of him, and his goal was to see his baby be born. And so over a 2-week period, every day I would check his blood counts. I would go in and see how he was feeling. I would give him pain medicine. I would order the blood transfusions. And finally, it came the day that his wife was going to get induced. So we gave him blood transfusions, and I rolled him down in his wheelchair to the delivery room where I saw him watch his son be born. He passed away about 6 weeks later. But being able to help him reach that goal, which was so meaningful to all of them, to his wife, to his son, who's now an adult, to know that he was there for that, to help someone reach that, to me, it was the greatest thing that you could do as a physician. And that, from that moment on, I knew that oncology was what I needed to do, that I really wanted to help people reach their goals, no matter what the situation. Now, fortunately, it's been 32 years, and we have had amazing advances in breast cancer and other cancers, including leukemia, and the kind of leukemia that he had is now curable. So what's also incredible about this field is seeing those amazing advances that change lives. And it makes me incredibly sad that he wasn't able to take advantage of that, but also incredibly hopeful, because I know that we're gonna solve this problem of metastatic breast cancer, just like we were able to solve that problem of leukemia. In the meantime, we want to make the best of what we do have. And we have many tools to help you get through the journey of metastatic breast cancer. And so I'm grateful to Komen for inviting me to come give this talk. I had a Komen grant as one of my earliest grants as a junior faculty member. They really believe in supporting young scientists with new ideas, and those types of grants make it possible to get started, and really led for me to many more grants. But if I had not had that initial seed funding and somebody who believed in me, I very well might not be standing here today. So I'm incredibly grateful to Susan G. Komen for that support, and I now am fortunate to be one of the Komen Scholars and to continue to be able to mentor younger people. So, is she ever going to get to her slides? I know you're asking that question. But I did want to just really set the stage. And I think setting the stage is important because today we're going to talk about lots of things related to metastatic breast cancer. And it's a topic that we don't talk enough about. And I don't have to tell all of you that. Those of you who are experiencing metastatic breast cancer probably feel like, hey, why isn't anybody noticing me? We're all talking about mammograms. We're all talking about prevention. Why aren't we talking about metastatic breast cancer? It's something we need to talk more about, and I really applaud Susan G. Komen for making this a priority. And they have made this a priority in terms of funding so that we can solve this problem. They asked me to talk today about your care team and quality of life. Not a topic that I usually talk about. I usually talk about new therapies. I actually don't have any of the recurrent stuff in my talk, but I'm happy to talk about that, so I'll make sure I save enough time to answer some questions about that. But I was asked to talk about managing your care team and quality of life. And I think that this is just as important as new therapies, because we can't ignore the fact that what you're going through with metastatic breast cancer is a life-changing situation. It is with you every day. And as Beth so elegantly said, everybody's journey is different. Metastatic breast cancer is not one thing. It is many, many different things. Comes in many, many different flavors. So it can be very hard to understand what your journey is going to be like, and to be able to find other people who are going through the same thing that you're going through, because we have lots of different forms of metastatic breast cancer. We have different types of breast cancer, like triple negative and HER2 positive and ER positive. Those refer to the biology of the breast cancer. When you look at those cells under the microscope, we see different proteins, and each of those types behaves differently. We also have different ways that the disease manifests itself. So some people have it just in the bones. Some people have just one or two spots. Some people have spots throughout the body. That is all metastatic breast cancer, but it looks very, very different. And then we have different kinds of ways in which breast cancer responds to therapy, and different therapies that we use for different types of metastatic breast cancer. So we really are talking about many, many diseases when we talk about metastatic breast cancer. We're also talking about journeys that can vary substantially for different people. So when I think about the trajectory of that journey, we really think about several different parts to it. The first is when your breast cancer is discovered, and if you've been through this process, it is very difficult, as you know, waiting for results, waiting to hear what are you dealing with. That is a process that usually takes days to weeks. We then spend most of our time giving treatments that target the cancer. And what's been incredible to see, and I was just talking to numerous colleagues from our pharmaceutical partners here about the new drugs that we are now seeing come into the clinic, and more to come. It's incredible, really an explosion of new drugs, new types of therapies. So we have so many things to offer, and that's what's so gratifying as a clinician, having lived through an era where there were times when I had to say, I don't have anything more to offer. It's so rare that I would have that conversation now, much more rare than it ever was before. So this is an incredibly hopeful time, and we believe that people will be in this phase of getting treatment for the breast cancer for years and hopefully decades. I've been in practice for 25 years now. I have patients with metastatic breast cancer who I've been managing for 10, 12, 15 years. You know, that's an amazing thing. There does sometimes reach a point where we can't do more therapy, but we have also incredible supportive therapies to focus on treating symptoms and making sure people feel well. We all, I think, grew up with the idea that cancer is pain, right? But we can manage pain so well now. And nausea, and the drugs that are available to take care of nausea are really amazing. So that has changed tremendously, and people even now are living quite some time not taking therapy for the cancer, but taking therapies to treat the symptoms. Unfortunately, some people do reach the end, and we're learning even more now about end-of-life care and how to make that part of the journey as comfortable and as tolerable and as meaningful as it can possibly be. And I think I speak for all of my colleagues to say that helping patients through that part of the journey is just as important to us as making that diagnosis or giving new drugs. That whatever part of the journey a patient is in, we have to attend to the need and to make sure that it's as comfortable and as manageable as possible, both for the patient and for their family. I think we also have to recognize that the disease acts differently in different people, and you're going to hear about health equity a little bit later. We know that patients of different races and ethnicity respond to treatments differently, have breast cancer that behaves differently. We don't know enough about this, and this is a very active area of research because we not only do we need to attend to the type of breast cancer, but we need to attend to you and the unique situation of your body, how your body responds to different therapies. We also know that the breast cancer can behave differently if you're premenopausal compared to postmenopausal, or if you have different medical problems. And so we're managing all of those things together. Lifestyle and genetics really go hand in hand. You know, there's things you're born with, there's things you're exposed to, and together, those really impact the kind of breast cancer you will get and how it will behave. And then finally, you know, we really are now focused, and I want to make sure you all know this, at the highest levels of our professional society, our scientific societies, to really deal with this issue of access to care. That it's been said that if we simply made sure that every breast cancer patient in the country had access to the most appropriate and cutting edge care, that mortality would drop substantially without ever seeing a new drug. Right? So think about that. We aren't getting all of the treatments we have to everyone. And so that's something that's now become a really big priority within DeField, to make sure that the treatments we have, which are so good, are getting to everyone. So despite the fact that there are so many things that are different about breast cancer, patients who have metastatic breast cancer are often dealing with many of the same issues, right? No matter what kind of breast cancer you have, we know that this is disease that's outside of the breast and the lymph nodes. And at the moment, we do need to give lifelong therapy, chronic treatment, and be monitoring. I really believe that there will come a day when we are able to say we have gotten rid of this disease and you don't have to take more treatment. But we're not there yet. So right now, this is a matter of being through chronic treatment. And I think one of the things that patients tell me is is the hardest to deal with is the uncertainty. You don't know what next month is going to be like, what next year is going to be like. How do you plan? How do you decide whether you're going to go for that new job, whether you can put down a deposit on a vacation that's going to happen in 6 months, right? That uncertainty is incredibly difficult. And it's hard for us too, because we want to be able to tell you what's coming. But I think about metastatic breast cancer like a game of chess, where we make a move and then the cancer makes a move and then we make a move in response. But we also are trying to think 5 moves down the line, right? And we want to keep all of our options open, but we don't know exactly what it's going to do. We've got a game plan, we've got a set of moves that we can make in response, but we just don't know what that's going to look like. And so I do love the message, Beth, that you gave about having that partnership with your care team who really knows you and knows what you are likely to experience, is understanding when something's different. When that cancer's made a move, they can pick it up because they know you. That is so important. We also know that the emotional burden of this falls not just on you, but on your family, on your friends, on your community. It impacts your work, it impacts decisions about your family. And so we really focus on the whole person. We aren't just taking care of a number, a test result, a lab value. We are taking care of all of you, because metastatic breast cancer affects the whole person. So you've got a lot to juggle. This is just one part of your life. And you know, I really do appreciate that so many of my patients are really like, well, yeah, I have metastatic breast cancer, but really that's not what I'm about. Like, I am a mom and I work and I do all these other things, and metastatic breast cancer, it's a part of my life. I have to manage it, but it doesn't define me. You are many other things that are not your metastatic breast cancer, and we need to help you juggle it. And so you need a team, right? Teams can do what one person alone cannot do. And so I was asked to talk today about, like, what should that team look like? And this is something we don't always talk about, and so I think it can be really helpful, especially if you're just starting out or if you're wondering what might be coming down the line. we all work together as a team. This is a team sport, oncology. And we work with people in other fields, other healthcare professionals. So here you see really a sort of integrated model of the different types of providers and supporters and physicians that you may encounter with metastatic breast cancer. It's not just your oncologist. It's not just the pain specialist. It might be the orthopedist who's going to help with a bony metastasis. It might be the physical therapist who's going to help after you've had radiation to make sure that you're able to walk without falling. It might be the palliative care team. We're going to talk about the palliative care team because this is something that's relatively new, didn't exist when I started in oncology, and something that I want to make sure everybody is aware of. So, and then of course on our teams, our advanced practice providers, our nurse practitioners, our physician assistants, our nurses, our research teams, our pharmacists. You know, I have the privilege of sitting down with my patients every day and talking to them about what we're going to do. When we make that plan, a whole team goes into motion to carry it out. Those are the people behind me really making all of it possible. And so that, I hope, provides a lot of comfort that there is a whole team of people there for you for whatever your needs might be. And so if you're just starting out, or if you're wondering, how do I put my team together? I find this to be a very helpful website. This is cancer.net. It is run by the American Society of Clinical Oncology, our largest professional society. And it has these very helpful sections on how to manage your care. So there's individual decisions about different treatments, but what I want to just emphasize is that you're actually managing a whole team. And if you're the manager of the team, you got to be thinking about who's playing all the positions, who you're putting into the game, and when you're taking them out, who do you trust, who is going to come through for you, and you have control over that. And so you get to take charge. And we want to talk a little bit about how you do that. So you have a lot of ways to advocate for yourself. I'm going to stand over here because I can't see this from over there. So we want you to ask questions. Come prepared with your questions. You also have the opportunity to ask questions through portals. I want to talk a minute about the portal because I think portals are confusing. It's wonderful to have the ability to access your team through a portal. It can also be incredibly frustrating when nobody's responding or when you are getting information through the portal at midnight or on a Saturday afternoon, right? I don't know how many of you have experienced this. Results coming through without the opportunity to talk to anyone about them. This is a reality of our healthcare system right now. It's something that we as providers really struggle with because we want to be there for you and we want to prepare you for information that's coming to you, and sometimes it comes before we have a chance to prepare you. And so talk to your doctor about how you're going to communicate. How are you going to do things through the portal? If information comes, how can they reach you? What happens if it's on a weekend or at 9 o'clock at night? How do you know that your doctor has seen this? We have systems in place to make sure that we have people monitoring the portals all the time. We want to make sure also that you're looking at things on the internet that are useful and accurate and not going down that rabbit hole of the scary stuff. Remember, people who are writing things on the internet about how awful their experience is are there because they are having a bad experience and they need to vent that. And I always say, remember, the people who are feeling fine, they're out doing stuff. They're not online writing about it. They're just out doing stuff. But if all you see is what's online, you might think that everyone who has metastatic breast cancer is miserable and in pain and having terrible side effects. But you're only seeing one side of the coin. You're not seeing all the people who are doing really well, who just don't happen to be online writing about it. So you can get a very skewed view of what's happening. And then that is why I think it is so important that when you do see things online, you bring it in to talk to your doctor about it. I have people bringing things to me all the time, and I love that because I want to be helping them interpret what they're seeing. So that's an incredibly important role of your provider to not just give you advice on how they want to treat you, but also help you interpret all of the information you're seeing come at you. And then let's talk about second opinions. So many patients are nervous. They hear they're supposed to get a second opinion. They're worried that if they tell their doctor they're getting a second opinion, that doctor's going to get mad. In oncology, we are all about the team. We expect that people will get a second opinion. We welcome that. And I have many patients that I would say I co-manage with providers that are, out in central Pennsylvania or down in Delaware, where the patients can't come see me all the time, but they come every once in a while, and we weigh in when there are big decisions to be made. So there are ways that you can really assemble your team to include multiple oncologists to help make those big decisions. You still need one person, one oncologist who is your main quarterback, who is going to really implement every decision, right? That's important. But do not be hesitant about getting a second opinion, because it really is very helpful, both for your doctor, who might see things in a different way, as well as for you. Even if you're hearing the same thing, that's very reassuring. And even just hearing things explained in a different way can make it easier to understand. These are just some questions, and I'm happy. I hope these slides will be made available to everyone in attendance, because I don't want to go through each of these. But I think it's helpful to have, sometimes people say, I don't know what questions I'm supposed to ask. Like I say, ask me questions. They don't know what to ask. So here's a list of questions that you can use, and we'll make sure this is available to all of you. So you don't even have to think up what the questions should be. I encourage my patients to make a list, and we always go through their list at every visit so that we have a chance to talk through things that are on their minds. And then clinical trials. So you're going to hear more about clinical trials later in the day, and that's not the focus of this talk, but clinical trials are an important part of treatment for metastatic breast cancer. It's how new drugs come into treatment most of the time. It can be scary because sometimes we don't know as much about the drug as we do about drugs that are standard of care. I think the thing I want to really impart here is how seriously we take the process of clinical trials, of investigating a drug. The care you get on a trial is much more intensive than the care you would get otherwise, because we have to monitor everything that's happening to you. We are learning about the drug too, and we have to be attentive. So you may have a whole extra team that is layered on top of your existing team. That's your clinical trial team. So that can be a research nurse, a coordinator, a pharmacist, all people who, in addition to your standard treatment team, are helping with the clinical trial. We also have some novel resources that can help figure out how you get to a trial. Many patients say, I don't really even understand what it means to be on a clinical trial. How do I find one? What's it going to be like? And so navigation and ambassadors, two things that we've been developing at Penn, can be very, very helpful. So this is our navigation program, breast cancer clinical trials at pennmedicine.upenn.edu. Many other places have this. All you do is send an email and say, hey, I want to know, am I eligible for a clinical trial? We'll do an intake. We'll look at all the trials we have. We'll let you know if we have something for you. And then if you are eligible for a trial, we have a set of ambassadors, people who have been through clinical trials who can help you understand what it's like to be on a clinical trial. Clinical trials aren't right for everyone, but we want to demystify it. The key is to make it understandable, take away as much of the scary part of it as we can, help you figure out if it is right for you or not. And it could be that a clinical trial is something you do at the beginning part of your journey. It might be something you do in the middle. It might be something you do towards the end. There's no set time for a clinical trial. Different trials are open in different places, and so we might have to help you find one someplace else. If we don't have it, let's help you find it someplace else. So you'll hear more about that today, later on, but I had to touch on that because I think it's such an important part of your team. And then side effects. So, really quality of life is really about feeling good, and, how do we help you stay feeling well? We need to deal with the side effects. We know that side effects affect most patients who have metastatic breast cancer, either from the cancer itself causing some sort of a symptom or from the treatment we're giving. And so this is really a major part of the management of metastatic breast cancer. We grade side effects, grade 1, 2, 3, 4, with 4 being the most severe. A quarter of all patients with metastatic breast cancer have a grade 4, the most severe type of side effect. So we want to be aggressive about that. Just because you have one of these side effects doesn't mean you have to keep living with it. We can take care of it. It sometimes feels counterintuitive when I say, oh, but I can treat that. So now I'm giving you a drug, and now I'm giving you another drug to treat the effects of the first drug, and then I have to give you another, and you're like, I am not a person who takes drugs. Like, I am not a person who does this. I hear this a lot, right? But if the drug for the cancer is going to help you live for years, then taking a drug to treat its side effects makes sense. And we know how these drugs interact. We know how to handle them. There's a big fear of becoming dependent on things like pain medication, but it's remarkably rare for somebody to become addicted to pain medicine when it's for cancer treatment. The pain receptors work differently in cancer patients, and so you don't develop tolerance the way someone who doesn't have cancer develops tolerance. If you need more drug, it's because of the cancer, not because you're developing tolerance. There's a misconception about that. And so I want to just put your mind at ease that becoming addicted is very rare, very uncommon, and it's because of the biology of pain receptors. So lastly, I want to talk about supportive or palliative care, because I think there's also a misconception here that when we suggest you see a palliative care provider, we think it's the end of the line. Nothing could be further from the truth. Palliative care is something we now integrate into treatment for breast cancer at every stage and at every part of the journey. So people who specialize in palliative care have a special certification. They've had to go through additional training to learn how to manage side effects. Now, I can manage a lot of side effects, but I am nowhere near as good as these people. So I can start as the oncologist and say, here's, I'll start with the standard drug for your nausea, but if that drug doesn't work, I need some help, right? And these are the people who help me and to help you. So I don't want you to be afraid if your doctor says, I want you to see the palliative care team. They're not saying we're giving up. They're not saying it's the end of the line. They're simply saying that they, your doctor or your nurse practitioner, need more help in managing your side effects. They need that expertise to really be able to give you the kind of support you need. These are all the different things that palliative care specialists can manage, right? And look, nail changes, they give me great suggestions about that. They can be even minor things like that. So these people are just, I treasure our palliative care people because they really help me give you better care. And it is integrated now. So it isn't something, in the old days, we talked about this as something that we would activate at the end of life. It isn't like that anymore. It has completely changed and become integrated into all of the care that we give. And there's data to show that it really improves a patient's experience. So it improves quality of life, reduces by 2/3 the symptom burden, just getting a palliative care team involved in your care. That's amazing, right? That's the proof that this is a really important thing. And 93% of people who receive palliative care say it really helped them and they would recommend it to others. So I just can't emphasize enough how important it is to have the palliative care team involved. And they don't just manage symptoms. They really help with other aspects of this disease that really can weigh on you. And sometimes it's easier to talk to someone who's not your oncologist about your fears, about what you're worried about. That can sometimes be a hard conversation to have with your oncologist. This gives you someone else who's sort of an objective person who you can share those fears with. Your goals, right? We want to know your goals. I often go into the room with my palliative care nurse practitioner. We did that the other day, just this past week. A patient had told her that she really wanted certain things and didn't want other treatments. She didn't want chemotherapy right now. She was tired of chemotherapy. She couldn't really tell me that. She told the palliative care nurse. The palliative care nurse shared that with me, and the two of us went in to see the patient together and have a conversation about that and why she wanted to make that choice. So it really facilitated the patient getting what she needed and being able to verbalize her goals. You can do this in the clinic and in the hospital. We also have people who can come to your house. Many things during the pandemic became possible at home. And so increasingly, some of our things that we can do in terms of managing symptoms can be done in your home. And if you don't ask, you don't know. So if somebody can come to your house and give you fluids and nausea medicines, that's great, right? Then you're not having to come into the clinic, which is an additional burden. Or some of the therapies that we give can be given to you even at work. So some of the anti-estrogen infusions, we go to people's place of work and give to them. So lots of things that we can do that don't have to happen in the hospital. And these are just some of the things that the palliative care group can facilitate for us. And so again, this is just bringing in more and more people to your team who are gonna help meet all of your needs as things evolve through your illness. Complementary therapies, I just wanted to say a word about that because I'm a big believer. I think that we should do everything we can to help you feel better. A lot of things we don't have medical evidence for, so our biggest concern is to make sure you're not doing something that could hurt you or that could interfere with your treatment, because that would be counterproductive, right? So what I show here is this wonderful website from Memorial Sloan Kettering that gives information about supplements and herbs. I use this all the time. You can use it too. It's free, and you just enter in whatever you've gotten from the grocery store or the pharmacy, and it'll tell you what kind of side effects there might be, what other drugs it might interfere with, because that's our biggest worry, is that we're gonna have something interfere with your treatment, and then you'd be getting all the side effects from the treatment and none of the benefits from the treatment. So this is really a wonderful website. Also, all of these other things like acupuncture, yoga, tai chi, massage. You heard Beth talk about Unite for Her. They provide access to some of these things. And acupuncture, for example, we have clinical trials that show that acupuncture reduces side effects. We don't know how it works. We don't care. It works. There have been randomized trials. So, you know, the important thing is to get you the things that will help you. And I love that Unite for Her actually makes this accessible to everyone, because I wish that we could provide these things free of charge to everyone. Unite for Her makes these things accessible. And then finally, if and when the time comes that we are looking at the end of the line, we want to be prepared. And so this isn't about what happens at the end, but about preparing for that. And just like you write a will, if you have children, you think about if something happened to you, who would you want to take care of them? It's just like that. You need to be thinking about what if? What if something happened and I took a turn for the worse? What kind of care do I want? And how can I verbalize that to my team so that they're going to do what I want? Because for me, the worst possible thing would be to have a situation where I don't know what my patient wants. So we talk about this early on, and it's an ongoing conversation. You can't always anticipate how you might feel in a situation where you can't speak for yourself, but you can tell me what your sensibility is. You can tell me what your philosophy is. We can talk about if this were to happen, what feels right to you? What do you think you would want us to do? Who do you want making your decisions? Who should I be talking to? And I meet those people early on, so we have a relationship. So God forbid we get to a point where things are ending, I'm ready, and I know the family, I know you, I know what you would want. And that, again, is a really important part of that relationship that you have with your provider. There's lots of great information on the cancer.net site about how to have those conversations and how to think about this. Bottom line, we know that coping with metastatic breast cancer is really challenging. It is not easy, and it is exhausting. It is relentless, and you need that, really, those arms to support you. And they're there. We want to make sure that even in the midst of all of this uncertainty and unexpected events that we know are going to happen, that whatever happens, you have the support you need with people you trust because you have generated those relationships early on. And being prepared with that team means that we can handle whatever comes our way. And that's the important thing. I don't know what your journey might hold, but I know we can handle it, particularly if we've assembled the team and I've got all of the people lined up for whatever you need. So you don't have to do it alone, and knowing the right questions to ask can really help put aside a lot of the fears, the uncertainty, and really expressing your needs is so important to us so that we know what you want, what you need, what you're experiencing. So I love this because it really says it all. There might be twists and turns, but our goal is clear. It's to provide the support you need to maintain a life full of the things that matter to you. So maintain, keep it going for as long as possible for the things that really matter to you. That's what we want. And we want to get to know you. We want to understand your needs so that we can provide that for you. Thanks so much for your attention. It's really a privilege to be here. I'm happy to take questions.